This is the Deltopectoral Flap. Deltopectoral Flap, one of the old workhorse flaps for head and neck reconstruction, largely supplanted by free flaps, but still an incredibly useful flap to have in your armamentarium for reconstruction of the neck, of the tracheal area, and also in cases where a free flap's not warranted, to that lower head and neck area. The blood supply of the flap's based off of the perforating intercostals from the internal mammary system, usually off the highest two perforators. Sometimes you can take it on 3 perforators. The flap itself is designed along the clavicle. So I've marked the clavicle here. You want to stay below the clavicular border, and you want to follow that line out. You can run up to, here is the deltopectoral groove, and up onto the deltoid. You can extend this further by a series of delay procedures if you need more flap. So in general, you'll elevate a flap based on the thickness that you'll need. Similar to other flaps, the wider the base, the harder the rotation will be to where you need it. So for something that's in the tracheal or neck area, a wide base is fine. For head and neck area, you may actually end up back cutting this flap just to include these upper 2 perforators. So for the deltopectoral flap, it's actually a very quick dissection. Once your flap is designed, I'll incise this down through to muscle fascia. And if you're potentially going to be using the pec muscle, pectoralis major flap, oftentimes you want, in combination with this, you want to do your deltopectoral first, get it out of the way, protect it, be safe, and then you can go and take your muscle. And here, if we talked earlier, if you wanted to delay this, you would not make this cut. We continue a series of delays back to make this a longer flap. But this can easily be taken out just beyond the deltopectoral groove. And again, down here, in this case to muscle. If this is in a woman, you want to take this flap above breast and try to avoid any of the breast tissue. And here we see pec fascia. We're now off pec, coming onto deltoid. We'll continue around. Deltoid fascia. And I'm just going to hold this for myself here. We're going to take this. You can take the fascia that's overlying the deltoid. We shouldn't see any of our vessels at this point. This is the fast part of the dissection. And as we come off of the deltoid, we can sometimes see our cephalic vein running into deltopectoral groove. Not part of this flap. Now we're over the pec. We want to include the fascia. You can see a small perforator here coming from the pec. That's not going to carry our flap. And we'll continue to work toward mammary perforators. Again, this is a pretty quick elevation, taking the fascia off the pec. And we can feel our interspaces. The vessels generally are within 2 centimeters lateral of the interspace that you can palpate. And as we approach, slow down the dissection, begin to look for vessels. We can see the beginning of a vessel running right here, a perforator. And there's a perforator right here. So once you reach these perforators, this is where you will stop your dissection. You don't gain anything by going further. There is another perforator that's in here. And this is a function of just being able to rotate your flap. So you want to make sure to release your skin and see your perforators. This is the largest of our perforator right here, so we'll stop. Now, I don't necessarily have another perforator right here, and I don't necessarily want to make the back cut through this perforator as well. Both this, and what's running in here will supply the flap. If we need to, we can. So if we take our flap now, we want to always see kind of what we need and where we are. So you can imagine for any type of tracheal stoma, pharynx defect, you have plenty of flap, and there's no reason to take this back at all. If you're trying to go intraorally or in the mouth, you may need some further length. You can hold this for me. In that case, I feel comfortable sacrificing this distal perforator and back cutting the skin. Here's my perforator right here up to that point to give us some extra length to this flap. So now we have some extra length to get where we need to in the head and neck area. You can see what you can get closed primarily in this flap. In a woman, certainly elevating the breast superiorly, oftentimes you can close a significant portion of this. It's often the area over the deltoid that needs to be skin grafted, or the entire area could be skin grafted. As I mentioned, certainly you could use the pectoralis muscle as a flap at this point, either with an independent skin island or taking just the muscle itself based on the thoracoacromial, which will be sitting right in this area here, also to elevate and rotate up into this area. And so here we again have demonstrated, here's this perforator. It's got a nice nerve running with it. You can see it's giving a branch to the muscle as well. And this pedicle can be dissected all the way down. And if you were to take this as a perforator flap, so-called INAP, or internal mammary artery perforator flap, we wouldn't need any of this muscle, and follow this through. And we would take a segment of the internal mammary or use it as a rotational flap off the interior mammary. We would literally remove a segment of the rib to allow it to advance superiorly. But here a nice demonstration of this segmental blood supply to this flap.